Okay, everyone, as we start diving into the nursing process in LPN practice in Chapter 1, I want you guys to be aware of the purpose behind this first assignment. We know that nurses give lots of medications, but I want you, as an LPN, to understand going forward how important it is that you understand the nursing process and, of course, using that in safe practice in drug administration. So, knowing and researching what you as an LPN can and cannot do will greatly protect your licensure that you have worked so hard to achieve. So, by knowing your limitations in practicing when you start out on a floor, this will help you understand what other nurses who may be your supervisor can and cannot delegate to you as an LPN when it comes to patient care and their safety. So this first assignment is basically researching the Nurse Practice Acts and why we have those. What is its particular purpose? How do they serve us as nurses? And then within those Nurse Practice Acts, you will locate the scope of practice for LPNs. You'll see here there are instructions and how I want you to write the brief summary about the purpose of the Nurse Practice Act. And then I want you to locate, when you locate the scope of practice for LPNs in Tennessee, you have instructions for writing about those specific medications. You can use Tennessee if some of you are going to be practicing in Virginia or North Carolina. You may use one of those. Those three are typically about the same as far as restrictions. So if you use another state, please be sure that you state that in your paper when you write that. Please follow these written instructions and submit this assignment as instructed. If you want to look at the files that are uploaded on Microsoft Teams, you will find that I have already attached the one for Tennessee. If you want to look at another state, you will have to search that for yourself. But Tennessee is attached to the files, again, on that Microsoft Teams website. So let's start with the nursing process. The nursing process, of course, is a series of planned actions or operations that we use to reach a particular result or goal. This process is systematic, it's rational, it's been proven over and over as an effective tool for individualizing nursing care. It never stops. It's a continual process for use in various facilities. It encompasses all steps taken by the nurse who are caring for these patients in order to achieve the goal that we're working toward. So this nursing process is universal. So you may transfer from one facility to another, but the process never stops. And once you get out on your own and you start working in different areas, you'll see that you do this process over and over in your mind without really even thinking about the steps. But in this part of pharmacology, we need to put the steps together and we need to understand what we're looking for in each step of the nursing process. So there's various steps. You first have your assessment. In this, you're basically establishing a baseline on your client. What is their normal function or what they might be at risk for? So that's where your assessment starts. Okay, then you have your diagnosis, planning, implementation, and evaluation. And we will talk about each of those in the next slide. So just know that the nursing process is an organizational framework and it may be used in other areas, but particularly for nursing, it is universal. Okay, so just be mindful of that. So in this slide, you'll see I have a diagram of the nursing process and the different steps that we go through, starting with your assessment. You have your objective data and your subjective data. You have your diagnosis, planning, implementation, and evaluation. You'll also see in the upper right-hand corner, I have a nursing diagnosis written in the three-part form, which is impaired skin integrity related to disruption of skin surface secondary to burn injury. So when we get into writing some of those nursing diagnoses, you'll understand them a little bit better. It always has to have three parts, and this is different from an actual physician diagnosis, so be mindful of that. So let's start with the assessment portion of the nursing process. So again, I said previously, this is just basically establishing a baseline for your client. You know, what are their normal function, what they might be at risk for, what are their baseline vital signs even. That will tell you a lot when you're looking into those things. There are two different types of data that you're assessing for when you start this process. And we will talk about the two different types of data in the next slide so that you understand those just a little bit better. That's very important that we understand that. So with our assessment, we have our primary source of data, which is going to be your patient sitting right in front of you. Okay. Many times we often have secondary sources of data, which are going to be your family members, especially with pediatric patients. You may have other team members who are then going to pass off to you. Typically, they'll use what they call an S-bar type of form when they're passing off report to you on your patient. Or let's say you have EMS who's bringing a patient into you into the ER and you're taking report. Okay, so those are your secondary types of data providers. So just know that you have primary, which is your patient, and then your other sources are going to be your secondary sources. And you will need to know one of the types of secondary sources. So when we talk about diagnosis, I wanted again to bring your attention to the one in the upper right hand corner. This is a primary example of a nursing diagnosis. This is not a physician diagnosis. This is something that you as a nurse are going to put together from your assessment data. So you're going to think about certain nursing problems, primary and secondary nursing problems, and we'll talk about what those are. You have your social, your psychological, your educational, meaning, you know, are they functioning at a 5th grade level or do they have a college degree? Okay, what is their environment like? Are they in a safe environment? Any nutritional problems that you can think of? So those types of things is what you're going to be gathering in your assessment in order to diagnose. So this is your nursing diagnosis. This is something that you suspect or you can gather from the data that you have obtained. So once we have our diagnosis that we've gathered from our data, we move into the planning stage. So this is where we set our goals. We're going to have a short-term goal and a long-term goal. These have to be measurable and attainable. So they're typically called a therapeutic goal. We need to know that we understand the drugs that we may suspect an order to be given for. With that, are there any special needs for equipment in administering those medications? Where do we start with teaching this patient? Actually, your teaching should start the minute they become, you know, your patient face to face. So you're planning, how are we going to get our patient to do what we need them to do to resolve the problem or the diagnosis that we've come up with over here. So that's your planning stage. So then how are we going to implement that? The biggest portion of implementation is your non-rights. Okay, we'll talk about those. Right patient, right drug, right dose, right route, the right time, the right reason, right documentation, the right response, and then always your patient's right to refuse. And we'll talk a little bit more about those as we go through this lecture. And then once we have assessed, we've diagnosed, we've come up with a plan, and now we've implemented that, we have to make sure that it's working. So are we seeing some therapeutic effects with maybe the medications that we've given? Are we seeing some expected side effects, or are we seeing adverse effects? This is your evaluation portion of the nursing process. So if we have not seen any therapeutic effects, or we have not seen an improvement in our patient, and maybe they're continuing to decline, this is where we're talking about a continuous process. It didn't work, so let's go back to assess what's going on now. Our patient, what do we see in the patient now that might have been different? Or we've tried one specific drug, so we have something else available. Let's see if that works. So then you go all the way through that process again. You assess, you diagnose something different, you plan something different, you implement it, and then you evaluate it again. So you can see that never-ending cycle in the nursing process. So as we move along, just keep that in mind. It's not just about knowing the 5 portions of the process, but you need to know what's involved in each step of the nursing process so that you can better put this into play with your patient and their care. So be mindful of the steps. You will need to know each and every one of those steps and what's included in each step of that nursing process. And we'll learn more about those as we go through this lecture. One of the important factors of assessment, of course, is always going to be our patient's drug history. Now, with that being said, our patients are not always the best historians when it comes to their medication records. So you may have to resort to your secondary sources, your family members or past medical records. Some patients, especially your elderly patients, will bring in a list. They may have 15 medications that they're taking, and it's hard to remember those, but they may have a little sheet that they bring in every single time. But we always want to do a reconciliation to ensure that those are correct. Maybe that was a list that they were taking 6 months ago, but they actually had a change in status, and now we've added a medication for high blood pressure, or we've added insulin for, glucose levels, or a medication for pain. Okay, so we want to make sure that we are assessing the accuracy of it, and we also want to make sure that we include any drugs that we know are considered drugs, but a lot of patients, especially in the elderly population, don't always consider over the counters as drugs necessarily, so they forget to list those. So you want to make sure you're including things like aspirin, especially when you're doing a reconciliation, because if your patient's taking a medication that's a blood thinning agent already, we want to make sure they're aware of them, what I would call double dosing for blood thinners. Vitamins, most patients don't ever think about those. Laxatives, cold preparations, and of course your antacids, your Tums, and things like that. So those are some over-the-counters that you would want to make sure that if your patient's taking, that we ask for those specifically, because they don't always include them. Supplements, are they taking any type of other therapies? Do they take herbals or using types of oils, things like that? Do they have an implant? Some patients have implants like birth control or pain control even. So you'll want to make sure that you're assessing for all of those. So drug assessment is one of the big factors, and most importantly, when you're assessing your patients. You can see on this one, most of our patients can't even pronounce them. I've been a nurse for 10 years, and there are some that I can't pronounce myself. So we try the best we can with what the patient gives us. You can see my little cartoon in this slide. She's calling for her refills, and I'm sure she's trying to say metformin, lisinopril, metoprolol, atorvastatin, but you can see how difficult some of these medications can be for our patients. So that's why I would always encourage my patient to keep an up-to-date list and take that with them anytime they go. If they don't have a list, then they're always going to have to take those medications in with them so that we do an accurate drug reconciliation. So important factor of assessment is going to be your drug history. And when we're talking about drug history, of course, as I said, most patients don't even know what they take, let alone why they're taking it typically. And so you can see my little cartoon. I love these in pharmacology because pharmacology tends to be intimidating and boring at times. So you can see I have him over here saying, you claim you have no medical history, or I would say you have no drug history, but your prescriptions for 10 other things was a lie. So a lot of times they have no idea. So we just work with what we have most of the time and refer back to the most recent drug history or the most recent data that we have. So another thing you want to make sure you're asking is that working for them? So I started taking a blood pressure medication about 3 weeks ago, 4 weeks ago. So is my blood pressure leveling out? Is it doing what it's supposed to be doing? Am I taking something for high blood pressure and my blood pressure is still high? So is it effective? Okay, now I've started taking this medication about 3 weeks ago, and surely by now your patient would have seen some adverse effects of those drugs. So you want to be sure you ask that. They may not recognize some of those adverse effects. One particular medication that we give for, I can't think of the name of it, but we give it for blood pressure, and it can cause a cough, just unexplainable cough. That is not necessarily meaning that they have anything going on that would cause a cough. It's just an adverse effect of that drug. So they may not recognize it as an adverse effect. They may just say, you know, since I started taking whatever the medication is, I have this cough. And so you'll want to chart that when you're doing your medical or your medication reconciliation. You always want to chart that because most of the time, people who pick up their medications, they look at the name of the drug sometimes. Sometimes they don't even do that. And they throw away those little papers that the pharmacy gives you that explains the side effects or adverse effects. They don't even know what half of them might cause. So we have to be mindful of those. So some of the things to be mindful of is Coumadin and warfarin. Okay, we talked about taking those and aspirin. So we want to make sure that we're not double dosing, as I say. So just kind of looking through the slide, just looking at what, you know, some of the things they may be taking certain medications for. So Coumadin and warfarin, prevention of blood clots. Are we seeing blood clots in that patient? Do we give that patient something else, AFib? Is his heart rhythm changed? What are his blood levels? His PT, his PTT is INR. So when you're on a blood thinner, they're doing those types of labs to see, are we at that therapeutic level with those medications? Okay, and then again, is this patient nauseous? Have they had a loss of appetite with certain medications? You'll find as we move through this pharmacology class, many times loss of appetite and weight loss comes as a side effect of certain drugs. So just be mindful of those. That's just one example for you to look at as far as a drug history and medications and deciding, is it therapeutic or not? Is it working or not? Okay, so just be mindful of that. So when we talk about the assessment phase of the nursing process, this is where we were talking about the objective versus the subjective data that we're going to gather, either from your primary source or your secondary sources. So you absolutely, positively need to understand the difference, because when you're testing, you need to know if it talks about objective or subjective information. So objective information is something that is seen, heard, felt, or can be measured. So this is going to be your lab results, your x-rays, your CT scans, your vital signs. Don't forget to include pain in that, your pain rating, palpation, auscultation. So what did you hear? What did you feel? What were your results from those labs that you sent? Excuse me. So an example of objective data is going to be, was there a presence of cough? Did you hear crackles when you were listening to those lung sounds, or bronchi? Was there edema when you were doing your assessment of that patient? If there was edema, what did you rate it on that edema scale? What does their input and outtake or intake and output look like? Is it they're taking in more than they're putting out, or vice versa? Were there broken bones, masses, tumors? Those are things that you can actually see on X-ray and CT and things like that. So those are going to be your objective data points. Okay, so subjective, an easy way to remember objective versus subjective is S always equals says. So subjective data is basically what can only be verified by one person. That one person is your patient. So if your patient says, my eyes are itchy, I have back pain, or I have certain feelings or emotions, or I feel stressed, that is your cue. I feel nauseated. I personally, as your nurse, I can see that maybe you're nauseated because you have some maybe vomiting and the urge to vomit, but I can't feel what you feel. I don't know how you feel pain. Everyone has their own threshold when it comes to a pain level. So you may rate your pain on a level of 10, on a scale of 1 to 10, and we may have broken the same bone or we have the same condition at the same stage, but I feel like I have a higher tolerance of pain, so I may rate mine at a 4. So that's your subjective data, is what a person feels, what they say. We can't determine that. If they are laughing, joking, carrying on, and they still rate their pain at a 10, we have to believe they're at a 10. We can't just say, oh, I measured it by whatever, and you really are not a 10. We can't do that. Okay, so the subjective data is the problems that are stated in our patient's own words, their belief about their condition, how they feel about it, or their perception of what's going on, or how severe their problem or their diagnosis might be. So you need to know the difference in the two. Remember, objective is something that can be seen, heard, felt, or measured, and subjective is always something that your patient says. Okay, so that's how you differentiate between the two. So as we move along in the nursing process, we're going to talk about diagnosing. Now, we all know that we are not a physician, we are nurses, so our diagnoses are going to be different from those of an actual physician. So a medical diagnosis is different in that it identifies the disease a person has or is believed to have. So that's going to be the difference. A medical diagnosis provides a basis for prognosis and treatment for that particular patient and whatever is going on with them. So COPD, hypertension, diabetes, anxiety, obesity, those are just a couple of examples of a medical diagnosis. Okay, so that is a diagnosis made by a physician. So the difference is with a nursing diagnosis. So with a nursing diagnosis, we gather our information and come to a conclusion based on the data that we gathered and compiled from our assessment. So a couple of examples that I have on this one is a nursing diagnosis always has to have 3 parts. So you're always going to have what your suspicion is. So on this one, I used activity intolerance. It always has to have something that it's related to. So as you see in this one, it's a sedentary lifestyle. And then your third part is always going to be your evidence. What led you to that activity intolerance, that suspicion, or that diagnosis of activity intolerance? Your evidence is there was an increase in demand of O2 and shortness of breath, maybe when they're walking a short distance. So that's how you're going to see those nursing diagnoses written. Activity intolerance related to sedentary lifestyle as evidenced by an increase in demand of O2 and shortness of breath. Now, so kind of an example is, I think my patient has XYZ. That's your diagnosis. He has this because he has shortness of breath. when he's walking. So that's kind of just an idea or an example to show you or to explain to you how I came up with my 3-part nursing diagnosis. So we'll talk just a little bit more about those in the next couple of slides. So I just kind of wanted to get you started on those. You can see I have another little cartoon in here. I love those. For those of you who are in nursing school, you'll appreciate that one. Excessive stress related to chronic exams secondary to nursing school, as manifested by uncontrolled crying, extreme exhaustion, and hysteria. I think we can all relate to that one. So let's move on in the next slide, and we'll talk a little bit more about the differences with medical diagnosis versus nursing diagnoses. So just remember the difference in the two, okay? A medical diagnosis is on your left, and your nursing diagnosis example is going to be your 3 parts on the right. So when we talk about nursing diagnoses, there's actually an association for that. It's called NANDA. That's why we call it a NANDA, or North American Nursing Diagnosis Association. And their purpose is basically they define and classify and standardize all of the diagnoses that are made by nurses. I think there are 13 classifications. You don't have to know those, but just know that NANDA is the one that keeps up with all of our nursing diagnoses. So with a nursing diagnosis, this focuses on the person and their response to their health or their well-being. Okay, so nursing is asking how a disease or an illness influences an individual's functioning abilities, or how can we meet their needs. Okay, so if it's something that nursing staff and the client can treat without orders from the physician. So think of it that way. So you'll see here I have 2 different examples. I have the nursing diagnosis, which when we have done our assessment and we've gathered our data, we see the medical diagnosis at the bottom as pneumonia. So that leads us to an altered gas exchange, ineffective airway clearance, because this person has pneumonia in their medical diagnosis. You can see that with pneumonia, they may have a cough with thick yellow sputum. So that leads us to a nursing diagnosis of ineffective airway clearance. So activity intolerance, a risk for imbalanced nutrition, risk for infection transmission, and discomfort. So when you're looking at the 2, just know that a medical diagnosis is just going to tell you what it is, pneumonia, what that does, or what it is. It's an infection that inflames the air sacs, and it may fill with fluid. That's what pneumonia is. That's what it does. And then the symptoms that you will see from pneumonia. So the symptoms you see are the things that you have probably assessed in this patient that leads you to your nursing diagnoses. So nursing diagnoses, this is something that you can try to resolve yourself rather than waiting on a medical or a physician order. So ineffective airway clearance, activity intolerance. Okay, so we just don't get them up and walk for the day. Okay, or maybe we do need to give them some oxygen if they're on oxygen and it's increased. That would have to have an order. So we want to decrease the risk for infection. So we would make sure that we have all of our standard precaution signs up. We can implement those. We don't need a physician order. And then as far as comfort, we can try some of the distraction methods, different positions, put them in a chair versus in a bed, put them in different positions. If they're a COPD patient, sometimes they sit a little slumped forward because it's easier for them to breathe. So just trying to make them comfortable. So just remember that the medical diagnosis, you can see the difference again is what it is, what that particular diagnosis does or is, and you can see that explained, and the symptoms that you're going to see because of that diagnosis. So if you guys have any questions about the difference in the 2, write those down email them to me. I'll try to expand on those a little bit more. So just know that with nursing diagnoses, this is something that you have come up with based on your assessment data. Okay, and it's not what the patient has, but what you're assessing in that patient that leads you to this diagnosis. So that's the difference. Okay, again, if you have questions, please write them down, email them to me. We'll talk a little bit more about those. As we move forward in the nursing process with planning, this is where we set our goals and our measurable outcomes. So you can have short-term goals and you can have long-term goals. So in short-term, this is something I've given you an example. A patient would describe their pain somewhere under the 3 mark on a scale of 1 to 10, 30 minutes after receiving medication for pain. So a long-term goal for a patient would be that the patient would understand medication compliance prior to discharge. We don't know when that discharge is going to be, so that's going to be our long-term goal. So your outcomes in the planning stage, they have to be very specific. They have to be measurable and they have to be meaningful. If they're not meaningful to that patient, they're not going to work toward accomplishing that goal. They have to be attainable. So we don't want to set a goal so high or something so ridiculous that your patient will never reach that goal. And it has to be action oriented. We want to get them up and moving if possible. So we want them to be a participant, of course. We don't just want to give them medications. We want to incorporate some other things as far as, maybe some daily activities, some exercise if possible. But we have to be realistic and we want to see results. So all of those things, including a timeline, time oriented, we want to set that timeline. So we have discharge, but in an outcome, they have to be very specific and more time oriented rather than just discharge. So typically some of those examples would be my patient, let's say they're in and they've broken a hip and they're doing therapy. So we would set a goal for that patient to maybe on day 2 or 3 to be able to walk 100 feet without the use of oxygen, something of that nature, or without an increase in oxygen consumption, or something of that nature. So it's specific, measurable. Our patient could probably walk maybe not 100 feet, but let's say the distance of, half the hallway or something like that. But we have to put it into a measurable form. You can't just say half of the hallway. It has to be 20 feet, 50 feet, something of that nature, so that you have that measurability. And we don't want to set an unrealistic goal, like I said, for that patient. So when it comes to the planning stage, there's a lot that goes into this point here. So you have to know the difference between goals and outcomes. So just remember that outcomes have to be specific, measurable, attainable, realistic, and timely. So you have to give a time frame. You can't just say at discharge for your outcome. This outcome needs to happen prior to discharge. So we want to set that timeline, 1 day, 2 days, or something of that type of timeline. You can't just say prior to discharge. That's going to be our long-term goals. So just understand the difference between goals and outcomes. And if you have questions again about those two, then please let me know by email. Send your questions. I'll be happy to answer those. So here I've given you an example of planning, and this is based on your assessment and your nursing diagnosis. We're going to set that measurable, achievable goal for a patient. So I have included one here talking about moving from the bed to the chair at least 3 times per day. So that would be one of your outcomes. We have what we want to do. We're moving from bed to chair. We have our time frame at least 3 times per day. So that's the example here. So maintaining adequate nutrition by eating smaller meals, more frequent meals, resolving conflict through counseling, managing pain, and just the use of medication, which with pain, sometimes we know there are other methods of controlling that, maybe some distraction techniques and maybe some exercise interventions also. So just kind of be familiar with those achievable short and long-term goals. Okay, so assessment data, diagnosis, and the goals are written in that patient's care plan so that you've made your plan, but maybe our plan didn't work when we would go back to do our assessment or our evaluation. So we want them to see what we have planned to do the first time so that by trial and error, we can see what works. And with it being in the chart, then they're not going to repeat that same process. So we can move on to something else that may actually, in fact, work for that patient when the first round did not. So in the planning stage, this is where I mentioned previously that this is where we start to formulate a plan to get our patients to basically do what we want them to do or need them to do to get them where they need to be medically or physically to get them healthy. So this is where most of our education comes into play. This is our planning stage before we actually implement what we want our patient to do. So a lot of education goes into this part of planning. So not only on the behalf of our patient, but us as a nurse, if we don't know about a specific drug that may be prescribed, then we're going to do some research and we're going to learn about that drug because we have to teach our patients. We have to teach them why they're taking this drug. They need to know the action. We need to know the action of a drug prescribed, how it's going to affect our patient. Is it affecting their blood pressure? Is it affecting their glucose levels? Things of that nature. Are they having some CNS side effects? So we want to make sure that we know everything that we possibly can about those medications, contraindications. So with contraindications, what else do we have to know in order to even begin to question contraindications? Well, we need to know what are the medications this patient is taking. So you should have a med reconciliation available to you. So we need to really look at that, look at the interactions of other medications. We need to teach our patient about what to report to us so that we can then in turn report that to the physician, especially if they're in the facility. Now, if they're going home, of course, they're going to um, eliminate the middleman, as you should say, I guess. And they're going to call their physician immediately to report that. But if you're in the hospital, they will report that to you, and then you'll report that off to the physician. So you need to be aware of what to look for also. Maybe your patient can't talk. Maybe your patient is, I don't, maybe comatose of some state, but you have to be able to know what to look for yourself. So not only teaching your patient, but also knowing how this drug might affect or present itself in your patient when you administer that. So in teaching, we have a method that we call the teach back method. I particularly like using insulin as an example. I may have a newly diagnosed diabetic, never given shots before, and so I need to teach that patient how to administer that insulin. And they're going home so they can do that for themselves and do it effectively. So the way we teach, or we understand that they understand what we've taught them, is by the teach back method. So I'm going to do the first one. Let's say it's breakfast. I do the first administration for a high glucose level. And then at lunchtime, I'm going to ask that patient to return demonstration. So they're going to return that teaching back to me. They're going to, of course, check their glucose, determine whether they need to take insulin or not, and then they're going to actually show me how to administer that injection. They're also going to, what I'm trying to think of, they're going to talk back or discuss with me about the educational pieces, site rotation, Of course, proper use of equipment, that's going to also include putting it in the sharps container after use, not reusing needles. I'm going to quiz them or have them name so many side effects and what to report and how to store those medications. So that's our teach back method. So we teach them initially, and then they're going to teach us another time. So also in the planning stages, you have to consider our elderly population and how difficult it is for some of us as younger adults to read the print on medication bottles. So just know that there are larger prints available. We may have to request those from the pharmacy, but those are available for patients who may have some type of visual impairments. So there's a lot that goes into the planning stage, but education is certainly a huge piece of this. So when we're talking about the nursing process and the medication orders that we're going to implement, we need to make sure that we're verifying the order. I talk about this so many times because it's extremely important to verify those prescriptions and those orders if you're in a hospital. So if you guys will look on page 16 in chapter 2, I know it's moving forward a little bit, but I want you to get the understanding of this early on through the nursing process. And then we'll talk about it again in Unit 2 or Chapter 2. So in order for a prescription to be legal and correct, it must contain numerous parts. So number one, a patient's full name, date of birth, of course, the date that they're writing the prescription, the name of the drug, the route of administration, the dose, the frequency, duration, and a signature of a prescriber. In the next couple of slides, you'll see, I'll talk about that again about the signature. Sometimes you may have physicians who submit their prescriptions electronically. So they're going to have an electronic signature rather than a wet signature. So most of the time, again, those are electronically sent when they'll have those electronic signature. So just remember that you have to have all of those pieces and parts in order for that to be a legal prescription, okay? It's not just written on a piece of paper, scratch paper, sticky note, or whatever. It's an actual legal prescription pad that these are written on. It usually has like their drug identification number also on that prescription pad, or they'll just handwrite that number in. Also, remember that PRN medications, if you're giving a PRN medication, it must have a reason as to why you're giving it. So I gave an example here, headache or pain. Those are some of the typical PRN medications. Nausea even sometimes can have medication orders for different medications to help reduce nausea. So when they're writing those prescriptions, they're going to say for nausea or for headache or for pain or whatever. Okay, so it's extremely important. You can see I put in here that 1 in every 5 doses given in a hospital can potentially be given in error. So I also gave you the number of deaths that occur each year in the US from preventable medication-related errors, meaning if pharmacy or the nurse or someone else had verified that, triple checked that order or the medication before they gave it, something could have been prevented. So it's extremely important that we recognize that. So be sure that you understand and know what those legal prescriptions must contain in order to be considered legal. Because when you're testing, you're going to have to know, is that a legal prescription? Does it have every single thing that I need before I send this home with a patient? Okay, we don't want our patients coming back to the hospital when they've been discharged because our prescription was incorrect or written incorrectly or missing pieces and parts or in a signature especially. I've had that happen in the past. A physician brings in his prescriptions for the day if he's a surgeon. He has all of his pain medications written out, but he failed to sign one. And we sent it home with that patient not realizing that it hadn't been signed by the physician prior to putting that inside their little chart. So make sure that you're always looking for those that information, okay? So if you have any questions about those, refer back to page 16 in chapter 2. It'll give you all the information on legal prescriptions. As we're talking about giving medications or planning to give these medications, we need to know that we're giving this drug or what we're giving it for, first of all. We need to know how it works in the body and the desired effects. So if we're giving a blood pressure medication, we're going to have to naturally assess the blood pressure either before, typically, and after giving that to make sure that it's doing what it's supposed to do. So we want to know the negative side effects that could develop, what are our usual dosages, routes, and how often they're given. Not every medication is given on the same frequency. So we have to be mindful of those things. And then contraindications, we talked a little bit about those. We want to make sure that we know the contraindications for those medications. Of course, any drug interactions would be some of those, but what about thinking of contraindications? What are some of the things that you would not give this drug, or cases in which you would not give this drug? When would you withhold that drug? Based on vital signs or lab results or things like that. So think about some of those contraindications, okay? Um, I cannot express to you enough. If you do not learn anything else in this course, I want you to take note of this. If you do not prep a medication or you do not pull this medication from a vial yourself, label it, date it, do not give it. If you have a nurse who's rushing, she wants to go home, or maybe there's even a code or some situation in which a nurse would ask you to give a medication. You may know that medication, you may give it every single day, and you may trust that nurse with all your might. But I promise you, it can always come back to bite you. If you do not prepare that medication, do not give it. Okay? I know that nurses trust nurses many times, but we're human and mistakes can be made. We've talked about tall men letters. That's why they were created. It's very easy sometimes to maybe pick up a wrong medication that sounds exactly like what um, we're going to give, but it's a different preparation. So it's a different type of medication, but the bottles look alike, the medication names sound alike, and are almost even spelled alike. So it's possible that maybe your partner on the floor didn't have her reading glasses on and just took for granted that that was the correct medication. Even the pharmacy could make mistakes. We have dispensaries, yes, but they could also make a mistake and dispense the wrong medication in that dispensary. So you have to make sure that you're verifying that medication. So if you do not learn anything else in this lecture, know that if you did not prepare it, do not give it. Okay. And if there is any part of that order that is unclear, do not give that medication. You call the prescriber and you verify it. I don't care if it's 2 in the morning. I don't care if they just walked off the floor. You call them and verify that. There is nothing worse than having a nurse give a medication or feel as though they can't call that physician no matter what time of the day or night it is because they don't want to bother them. Well, I can assure you, I would rather bother them to clarify an order rather than give a medication because I felt guilty disturbing their sleep and then having to code that patient at 2 in the morning. So just be mindful of that. Okay, don't ever give it if you don't prepare it. And if there's ever any single part of the order that's unclear, don't give it. If they call or if you call and they clarify, then take that as an educational opportunity for yourself. Okay, don't ever be afraid to call and get that order verified, whether it's your pharmacy. Maybe you know the physician prescribed the right medication, but you're not really sure about the dosage. Just call your pharmacy first, then call the provider. Either way, make sure you get clarification. So you'll see in this example all of the things that are required for a proper prescription. So you have the patient's name, John Smith, date of birth, written correctly, legibly. You have the medication name, the strength, which is 100 milligrams. You have the amount that that patient's going to take. It's 1 tablet. The frequency is going to be by mouth. Of course, that's the route, but you're going to take this every night at bedtime. That's your QHS. How much to dispense? That's going to be 30 tablets, and you have to spell that out. So it has to be spelled out. You can't just write 30, because someone could come in and write 300 or put an extra zero and make it 300. And you actually have to have whether or not a patient is eligible for refills or not. It has the date and a signature on that prescription. So if you are looking at this one, this is a prescription that a pharmacist shouldn't have any questions about. So this is we have verified that this is correct. We can send our patient home with this, and they should not have any problems at all filling this prescription. Now, if you're working in a facility, you may see different prescription orders or different medication orders. So in the med record or in their orders area of the EHR, you'll see this type of order. You'll see that the medication at the bottom is vancomycin. And this is the order that this patient was getting on 8/10. So we've started vancomycin, but apparently they were taking clindamycin. So you'll see that discharge order. That's what that D/C means. So they're starting a new medication at 8:23. They DC'd the clindamycin, and then you'll see another order at 8 or 9:15 for potassium. This is how you'll see the medication orders in an actual electronic record. Now at the top, you'll see another prescription that's just written differently to be sent to the pharmacy. I don't see an actual wet signature, but it does have the physician's name at the bottom, probably an electronic signature. So the difference in the wet signature is just that it's actually written with a pen, pencil. That's what wet signature means. So electronic signatures are typically acceptable. I wanted you to take a look at this slide, particularly with some of the medication orders that are here. This is typically something you would see in a facility, in a hospital setting. There are certain requirements for prescriptions, and as I said, refer back to that chapter 2 when we look at that. When you're looking at this, look to see first if you can find the errors in these particular ones that I've given you. Morphine, 2 to 5 milligrams IV, Q 10 minutes, PRN for pain. Well, we all know that typically we don't write orders in 2 to 5. That leaves the nurse guessing how much medication should I give. You want a specific value, 2.5 for pain rating of 8 or greater, or 5 milligrams for pain rating of 10. You can have a scale, but you can't be that vague in 2 to 5 milligrams for the nurse to determine. So in the insulin, the big thing about insulin that everyone has to be aware of is that anytime you're talking about units, 25 U each, you actually have to write out units. So this is a completely incorrectly written order. It has to be 25 units spelled out. You cannot abbreviate units at all whatsoever. Levothyroxine, 0.125 milligrams by mouth daily. So I don't know if you have picked up on that error already, but you should always put your leading zeros. Never leave those off or omit those, because you could potentially miss that decimal point and give your patient 125 milligrams. So then we've overdosed our patient on levothyroxine, which is never good. So always put those leading zeros. Coumadin, 5.0 milligrams daily. Well, this one's a little different in that we don't have to put the trailing zeros. So you may miss that decimal point and give that patient 50 milligrams of Coumadin daily. So you can imagine how horrific that would be if you send a patient home on a blood thinning agent that is 10 times as much as they should be getting. So never put your trailing zeros, just put 5 milligrams daily. Now, Monest 0.5 POQOD. There's a lot with this one. You can see there's 5.5 what? Milligrams, units. We don't know. We know it's by mouth, and QOD would be, when you look at it, it's every other day. But they actually need to write that out fully, every other day, so that their patient understands that. And you shouldn't really use QOD in order scenarios anyway. So just take a look at this and be familiar with recognizing those errors and getting those verified with your physician. We're all human, no one's perfect. And so errors can occur. That's why we have a triple check system, all those safeguards to make sure that we're doing everything we possibly can to ensure that we're not overdosing our patient accidentally. So just be mindful of those. Look back over these that I've given you here, the examples, and just make sure that you understand kind of what you're looking for when you're verifying those orders. So one of the non-rights, of course, is the right patient. We always want to make sure we have the right patient. The last thing you want to do is, I worked in a surgery center, and the last thing I ever wanted to do was walk into the OR with the wrong patient. There's nothing more terrifying than getting ready to do a procedure and realizing that you have the wrong patient. And trust me, it happens. I've seen this on occasion, people with the same last name especially. So we always want to make sure we have two identifiers. So ask them their full name and date of birth. Do not walk into a room and say, oh, hey, are you Joe Jones? Because if you have someone who is hearing impaired, they may hear Carol Jones. And they're like, oh, yeah, that's me. And here we're starting out on the wrong foot because number one, we have the wrong patient and we didn't ask them for them to tell us our name. We asked them, are they so and so? So never walk into a room or anywhere and say, oh, hey, are you whoever? You ask, tell me your name and date of birth. Tell me your full name, date of birth. This has telephone number. That was one of the verifiers, but I have never used a telephone number to verify a patient ever. I always compare it with my admission bracelet. They typically have a medication bracelet on, and then of course your chart ID. They always have a medical ID number that you can verify with their bracelet. So nonverbals, you may have some of those patients who are nonverbal. If you work in an ICU, you may have a patient who's comatose or they just came back out of surgery. How are you going to verify those patients? So always verify the armband with your chart, your medical ID numbers, something of that nature. If you work in a long-term care facility, a lot of those patients are confused. They may not even know their names. So you typically have, of course, an ID band, and then they also have a photo ID of those patients in long-term care facilities. So you can use pictures to verify that patient. So just be sure that you're always checking two identifiers and that you're not walking into a room asking them if they're so and so, but you are asking them who they are. That's important to know. Don't ever ask them if they're so and so, because maybe you've picked up the wrong chart and walked into the correct room. And so then you're asking them if they're Carol Jones or Joe Jones, whatever it might be. But you're the nurse and they respect you, and they would typically never say, I'm sorry, I think I misheard you. Most of them will just go right along with you and say, yep, that's me. All they heard was Jones, and they're okay with that until they get in there and you're operating on the wrong leg or the wrong arm or the wrong eye. And this has happened. That's why we have these rules now. So make sure you're looking for that right patient. And we'll dig into this just a little bit more as we move on. But Always remember to use those two identifiers. Okay, let's try this slide one more time. So we're talking about the right drug. So when we talk about the right drug, we also have to include the right forms. Okay, so some drugs come in various forms. I've used the example of Tylenol. There's liquid, there's tablet, there's suppository. Okay, so make sure that not only do you have the right drug, but in the right form. Okay, so that's going to be your correct route. Also, when you're giving medications, you want to be mindful of the correct name. You should always be checking your patient. But one scenario is if you work in a labor and delivery unit or in a NICU, you may have at times experienced a case of twins or maybe even triplets. So you'll have baby A, B, and C, which is not uncommon for twins to be in the NICU and labor and delivery. And it is not uncommon for you to be caring for both of them. So be mindful of, just because you have the correct last name does not always mean you have the correct A or B, and it's not always the case that baby A and baby B are being treated for the same conditions. So be mindful of that. So when we talk about right drug, of course, we always, like I say, triple check things. So we also have look-alike, sound-alike drugs. And so they came up with a system called Tallman lettering system. And if you look on page 7 in your books, you'll see some of the medications that are look-alike, sound-alikes. And it's very easy, if especially the packaging even looks similar. So some of them that are in the table 1.2 are Prilosec and Prozac. Well, we know those are given for two very different things. So if you're given Prozac and you still have someone who's crying and you're not seeing any improvements, then maybe you gave them Prilosec or Klonopin and Clonidine. They're both two very different things. Klonopin is sometimes given for seizures, and Clonidine is typically used for blood pressure. So you can see how important it is and how easy it could be to give the wrong medication. A lot of them do sound alike and look alike. So that's why they came up with Tallman lettering, to avoid some of those medication errors. So again, always be sure you're checking your medications 3 times before you give it. So before you take the drug from a unit dosing system, when you're preparing that medication, and then of course before you actually give it to the patient. So that's going to be your 3 times. There's on page 7 also one of the top tips for safety that will give you your 3 times that you look at that drug label. There is a video also attached to this. If you will watch this video again, I always tell you to watch the videos. I highly encourage them because something might trigger you when you're taking a test, and you'll recall that video and maybe remember that answer. Or you may be out on the floor working night shift and there's just 2 of you, and maybe something that you saw in a video will come back to your memory. So always watch the videos that I put in these lecture slides. Okay, so hopefully this slide saves correctly this time. If not, I'll send out an email. I'm not sure what happened to the first one, but anyway, just know that you always want to triple check those medications before you give them. This slide I placed in here so that you can read through this particular scenario, because this is a true case. This truly happened in a labor and delivery unit. So look at the difference when you're reading this scenario about ephedrine and epinephrine. So this is where we first started with Tallman lettering, is when this incident occurred. So I know in our facility, this is when this came about. So make sure that you read through this scenario just to see the difference in the 2 medications and what happened when she gave one versus what should have been given, and how detrimental that could have been. Fortunately, this patient lived and they were able to correct giving the wrong medication. But think about what can happen when you're given epinephrine instead of ephedrine and vice versa. So look at those side effects and think about that as you're reading through this scenario. As we move through our non-rights for our patients, we're going to talk about the right timing or the right time for medication delivery. There are several factors that we have to look at. Of course, one, the order and the timing intervals. Now, sometimes in a facility, there are medications that they give on certain schedules, like 8 and 8 or 2 and 2. It just depends. Okay, if you're in a hospital, they don't care if you're sleeping at 2 a.m. Um, so if it's given twice daily, that may be the time that they have determined for that facility. So it's really facility-based guidelines as far as when you're going to give those medications. Some medications are given at times so that peak and trough levels can be drawn. Now, I don't know that the reason they give them at certain times is based on staffing availability in the lab, but it could be related to that. So always check your facility guidelines as far as your dosing. Now, another important factor in giving your medication as a nurse, of course, is always giving it on time. We always want to be timely, but we all know that things happen and time can be stretched, but it is imperative that we do our absolute best to get those medications to our patient on time. Now, some facilities will vary on what they allow as far as on time. They can either give those medications 30 minutes early or 30 minutes after the scheduled time. So just be sure that you're checking again your facility guidelines. That will give you your 1 hour window to deliver it to that patient. And we really want to strive to make sure we're not late on any medications. Also, when you're giving medications and you're giving a PRN medication, we all know those are requested by the patient, usually for pain or headaches or something of that nature. So you always want to make sure, of course, that you're charting the time that you gave that, because we always want to go back and assess. Typically, a facility guideline is about an hour, within an hour, if you give an oral medication, to make sure that that medication you gave is in fact producing the effect that we want to see. So I gave a medication at 9 o'clock for a headache. They rated their pain on a scale of 1 to 10 at about an 8. So in about 30-45 minutes, I'm going to give that oral medication enough time to begin working. I'm going to go back and reassess that pain level. So if I go back and my patient then says, oh, my pain is a 3 now, then I'm going to go back to my charting and I'm going to chart that pain rating of 3 so that they can see that I gave a PRN medication and it worked. So it kind of gives them that opportunity. Now, the importance of attaining therapeutic levels when it comes to some of the medications and their timing is very important, especially with antibiotics and anticoagulants. I have both of those listed in here. Those are very important, and I know you are going to you probably already know why, but we're going to talk about it. So if you have someone who is septic or they have some type of infection like a staph infection or meningitis or endocarditis, we want to make sure we have a steady flow of antibiotics in the body so that we do not give that infection an opportunity to either become resistant or, infections and viruses are always morphing into something else. So we always want to make sure we have a therapeutic level of circulating anticoagulants and antibiotics in the body. So of course, this leads to compliance. We always want to make sure when we're talking about antibiotics that we are educating our patient on taking the full dose. Yes, you may take about 3 or 4 days and you start to feel some better, but we always want to make sure that we encourage them to take the full dose as prescribed so that we do not run into those instances where we have a resistant type of infection. Okay, because at that point it limits the types of drugs and the number of drugs that we can use to treat them. So let's talk about peak and trough. So some of you may already know, but peak and trough levels are what we typically see drawn with antibiotic use. This is typically when vancomycin that comes to mind, particularly because of the toxic, or I guess effects that could, or side effects that could happen because we are not at therapeutic level and they've become toxic effects or overdose basically on the medication. So a trough level is drawn immediately before your next dose. Now, typically the drug is administered and they'll do a baseline blood draw. Okay, so typically that's going to show that they have nothing in their system. So they're going to do a trough level when they go to give that next medication. So let's say you give it at 8 and 4. So you give your medication at 8 o'clock. You've done your pre-draw. So at 4 o'clock, they may want to see a trough level to see what that baseline is or what that has changed from baseline. So then as far as a peak level, that's typically drawn within about an hour or two. Again, that's facility based. They determine that. So check your facility guidelines. But typically the peak level is drawn within about an hour after you administer that medication. Okay, so you guys need to know what peak and trough are, what they're used for, and the timeline for drawing them. Okay, so know their purpose. So another thing with dosing in the right time, of course, is going to be medications and their interactions. Timing can also relate to actions. So let's say, for example, if I'm taking diuretics, I'm going to want to take that first thing in the morning because I don't want to give that to my patient at night so that they're up and down all night long going to the restroom. That's not feasible. So we always want to make sure we're considering the right time for medications such as that. Other instances would be antacids. Those always interfere with most other medications and their absorption. So we have to be mindful of timing when it comes to that. Typically around 2 hours. So that's why sometimes you'll see drugs scattered about and you wonder to yourself, why can't I just go in and give this person their medication? I have to go back in there every 2 hours because they have 20 medications on a list. Yes, you're going to have that happen. And that's the reason why. So as we move through pharmacology, you'll understand why you can't just go in and give them all 30 of their pills for the entire day. So yes, there are other things we need to consider. Right time, of course, I put a little note here at the bottom that says don't ever leave a medication laying at the bedside. Well, that's because sometimes you'll go in, maybe your patient is on the phone or whatever excuse they might want to give you, and they'll just say, just leave it on the bedside table, I'll get it in just a minute. Never do that. I can promise you that you're going to have those patients, and I have witnessed it, I have been a victim to it. They will pretend even sometimes to take that medication and they'll let it slip down into their sheets. And then you'll notice that a little while later, they have actually snorted that medication. They've crushed it and snorted it, especially with opioids. And then you pick up on it. So don't ever leave it at the bedside. So if someone wants to, I guess, be evasive, you'll pick up on it. As a new nurse, that happened to me. I thought I saw it drop onto the sheet, but I wasn't 100% sure. And as a new nurse, I was afraid to confront that patient. And so I learned how to deal with that, but never, ever, ever leave it at the bedside because you don't know who's going to take it at that point. You may have a small child that comes to visit. And so if you leave any type of medication there, you know, anybody's susceptible to the responsibility of that. If you have anyone who takes it other than the patient, remember you are responsible for that. So always make sure that your patient takes their medication before you leave that room. All right, so if you guys have any questions about dosing at the right time, please email those to me, okay? So now let's talk about the right dose. Doses are, of course, based on an average adult. We all know that if you're working in a pediatric area or a neonatal area, we all know that those are going to be very different from the average adult dosing. So always be sure that you are verifying that is a safe dose for whatever patient you may have. Okay, so again, they're based on an average patient. And remember, that as we age, our metabolism and things tend to slow down. So a patient who is older may need a reduced dose. Okay, and we'll talk about that a little bit later on, but just know that based on different disease processes and age, of course, are factors in those reduced dosages. Okay. Now, a lot of times pediatric doses, especially in the NICU, are weight-based. They're not based on an average child. So those are very different. Okay, so this is just your average semi-healthy adult are the ones that are going to receive those average adult doses. Okay. When we talk about proper dosing, we also want to talk about proper equipment when we're giving that dose. So let's say we're giving some insulin. Okay, of course, we're going to use an insulin syringe because we all know that not every syringe is correct or accurate for dosing insulin. Insulin is given in units, and of course, we always want to make sure we're following the safe administration practice, that we check that with 2 nurses, okay, because insulin is in fact a high alert medication. So you'll draw up your insulin, you'll have someone else usually look at it, verify, and they're going to actually sign off on that medication administration for insulin. So be mindful of that, okay? Safety checks. Always read the labels. Make sure you're giving the correct insulin. There are various types. You have short acting, long acting, things of that nature. So make sure that you're in fact giving the right dose of the right medication, okay? So remember 2 checks. There are several medications that are considered high alert medications, particularly insulin, heparin. So make sure that you're always double checking those. Triple check is what I always say. Read your labels carefully. Okay, remember we talked about the tall man letters. So always, always, always double, triple check those. Okay, if that label is not on there, call the pharmacy and say, hey, I have a medication, can't read the label, or it's missing, or it got wet in transit. Something is not legible. I cannot administer this medication. Okay, a lot of times medications come from the pharmacy that are already pre-mixed for you. Always make sure that you're comparing your concentrations on the medication that is sent to you from pharmacy with the dosage that your order is written for. Okay, don't ever be afraid to call the pharmacy and say, hey, I just want to check this, because again, I've said a million times, none of us are perfect, and that is why we have those safety checks in place. So if the physician writes it correctly, pharmacy may misinterpret or misread that order, and you call back to check that order because you feel like it's unclear, then maybe you'll catch that. What could potentially be a harmful event. Okay, so never ever ever be afraid to call a pharmacy and double check that. So remember, always read your labels, check your concentrations, always use your appropriate syringes for administration of medications, and we'll talk about syringe usage later on in our next unit. Okay, but always make sure that with insulin, you remember that there has to be 2 nurses because it is that high alert medication. All right, so the right to refuse. Every patient has the right to refuse. That is one of the premier patient rights, okay? So we have refusal for treatments, but it's also the same for medications, okay? So clearly there are some times when a patient just doesn't want to take the medication because they're afraid of some of the side effects, or they don't really understand what the side effects are going to be, or what is this going to do to me, what's this going to do to my body, how is it going to affect me. So this is where our teaching moments happen. Okay, we want to ask them why they don't want to take this medication or why they're refusing it. Okay, so um, some patients, of course, one of the examples I think in your book is talking about laxatives. Well, of course, if we've been giving them laxatives for the last day or so and they begin to have diarrhea, of course we're not going to give them a laxative. That's clearly one of the best reasons to refuse. So that patient doesn't really need to be educated. We know why they're refusing. Okay. Other times when we might have a patient refuse medication would be pain medication. Not really feeling any pain right now. I'm okay, but if it's a PRN, I might ask for it later. Not a problem. So we understand why they're refusing. But the times when they refuse important medications such as blood pressure medications or any medication, insulin, anything of that nature, any medication at all whatsoever that they don't understand, but we know as nurses they really need this medication, then we need to dig a little deeper and educate them as to why we're giving it, the side effects, what to report, what to look for, and how it's going to affect them. Okay. Make them a little more comfortable so that maybe they are more compliant, I guess is what I want to say. Less refusal, more compliance. So when we're talking about drug administration, don't forget also that blood is also considered um, a medication in facilities. So Jehovah Witness is a prime example. Most of them refuse, nearly all of them refuse blood products. Okay, they have a right to refuse based on their religious beliefs. Now, I worked in the NICU for years, and we had an infant who was born to a family who was Jehovah Witness, and of course, this infant needed a blood transfusion. This was life and death. It was a life and death instance for this premature infant, and the parents simply could not sign the paperwork. They refused to sign the paperwork. So, of course, we got the ethics committee involved, and we actually had to get a court order to give this blood product to this infant. And that was okay. The parents couldn't sign consent, but we got an order to give that. So just be mindful of the fact that we always we're always thinking about medication, but patients also have the right to refuse blood products and things like that. So again, different spectrum, same right of refusal. Now, there are some exceptions to the right to refuse. Of course, many of us know that that would be in a psychiatric unit where a patient may refuse that medication, but really, do we want them to refuse and accept that as or take that as acceptable? Because they could potentially be taking a medication because they're harmful. They could become harmful to themselves or others. Okay, so just know that the right to refuse is there, but there are always exceptions to the rules, okay? Just like in everything else. So, certain states have emergency treatment orders, so you need to be familiar with those. If you are working in an ER, I would certainly familiarize myself with those. Check with your facility, but just remember the right to refuse is there, but again, in those psychiatric facilities, it's based on whether or not they're a harm to themselves or others. Okay, and usually someone else is involved in making those decisions as far as continuing that administration, even though that patient says, no, I don't want that. No, I'm not taking that. Okay, so any questions on the right to refuse? Again, email those to me. I'll be happy to discuss those further if need be. And last but not least, evaluation. This is the end of the nursing process. This is the end, but it's still important. Okay, so how did the patient respond to the interventions? Okay, we assessed them, we came up with a plan, we went through our non-rights, and so now we want to see, was it effective? Okay, so the example in your book was an antipyretic, or let's say we gave Tylenol, okay, to bring down some fever. So were there any adverse effects? Okay, did the fever come down? How, did we give it twice before it came down? If it didn't work, what else are we going to do? We're going back to the assessment part. Okay, so we gave a blood pressure medication. The patient came in, it was 210 over 100. So we gave an antihypertensive, something for that blood pressure. We took that again in about an hour. So did we see a change in that blood pressure once we gave that medication? So was it effective? That's the whole point of the evaluation part of the nursing process. So if it didn't work, we go back to the assessment. We're going to diagnose, look at our diagnosis. We're going to plan and implement something else. Okay, so it is a never-ending cycle, just like I said previously. Okay, so evaluation is always important. If it's not effective for your patient, why are we doing it? Why are we continuing to do that? Okay, so we always want to make sure that we are doing a proper evaluation. Pain medication, if we're giving it and it's not easing their pain, why do we continue to give that same medication? Okay, we may need something that works in a different pathway. So keep that in mind. When you're evaluating, it's the end of the nursing process cycle, but it's a never-ending cycle. Okay, so an easy way to remember the steps in the assessment or in the nursing process is ADPI. Okay, that's your assessment, your diagnosis, your planning, implementation, and evaluation. Okay, so that covers the nursing process. If you have any questions at all on any of those portions of the process, please jot them down and email them to me. Okay, if you're not sure about the different sections or steps within each part of the process, please email me and let me know. Okay, this is challenging for everyone, but I want you to understand that I do not mind at all to send an email to elaborate on any of the slides that you have here. Okay, so if you have any questions, please email those to me. Drug responses. So there's three different effects when we're talking about drug responses. So first, let's talk about the therapeutic effects. Of course, we all know that therapeutic means it's working, it's at the proper level. So for the dosing, it's exactly where we need it to be. So the purpose of the drug, did it do what it was supposed to do? That's our therapeutic assessment, and that's where we decide yes or no. So we give a laxative for constipation. Patient has a bowel movement, therapeutic response. Anticoagulants. If you have a patient who's taken some type of blood thinner for whatever reason, and we're drawing those labs on a regular interval, and they're within that therapeutic range, then that's a therapeutic effect from the medication that they're taking. So those are the kinds of responses that we want to see. We want positive effects when we're referring to therapeutic effects. It's working, so let's keep doing what we're doing. We don't want to keep giving them laxatives, of course, but with the anticoagulants, they're therapeutic. They're within those lab level ranges. So we're seeing the effect that we want that drug to perform. So expected side effects are unintended, but occur in a lot of people that take the drug. So with opioids, we always use that as an example. Opioids, of course, are used for pain. So with that typically becomes sleepiness. We expect that to happen. So that is not harmful to our patient unless they're operating heavy machinery or driving, then it could be. But we expect that to happen. It's not harmful actually to the patient themselves unless they're doing something that might cause them to harm themselves, if that makes sense. So expected side effects is just something that we expect to see. It's been tested. We've had thousands of reports of certain side effects, but they're not harmful to that patient. Okay, again, going back to harmful to the patient versus harming themselves. Okay, so expected side effects might be sleepiness, which is not really harmful if I go take a nap because I've taken medication for pain. However, if I'm operating heavy machinery under the influence of that opioid, at that point I could harm myself if I fall asleep at the wheel or something of that nature. So just know that expected side effects are not harmful to the patient in and of itself as far as a side effect. Okay, we always want to document them even when they are expected. We don't want to just say, oh, that's an expected side effect, it's okay. We always want to report that and document that our patient has experienced that. Okay, so now adverse effects are often something new or different. It's possible a lot of times when you get your drug information from the pharmacy, it will tell you adverse effects. And those are typically side effects or adverse effects that have been reported from patients who have taken that medication. May not happen to every single person, but again, we're all different. Our metabolism is different. Our body reacts differently. So not everyone will experience the same side effects or adverse effects. So the thing to know in order to differentiate on testing, of course, is an adverse effect is harmful. It absolutely 100% of the time must be documented, reported, and often we're going to have to do some type of treatment, some intervention, especially when we think about adverse effects in relation to allergic reactions. So when we refer to those allergic reactions, you may give a patient a medication, and we always want to make sure that we have available equipment at the bedside or at least out in the hallway, just in case we were to have an allergic reaction that is severe. Signs of anaphylaxis, so a sudden wheezing, or they just cannot breathe, or they're turning blue. Okay, that's a sure sign of harmful allergic reaction, and we will want to treat that immediately. It's harmful to the patient. Okay, so that's one of the adverse effects. Remember, 100% of the time we want to make sure that we are reporting those. As you guys start to look at this case study, we're talking about a 65-year-old male with liver cirrhosis. So immediately you should begin to think about the absorption and the metabolism portion of drug administration. Now he is experiencing some nausea and vomiting post-surgery. He also has a diagnosis of heart and kidney failure. So anytime you think about kidney failure, you have to think about excretion. Okay, so anytime we're thinking about excretion and that impairment, you have to think about medications remaining in the system for an extended period of time because they're not being excreted correctly. So therefore, we run the risk of overdosing our patients if those doses aren't adjusted to whatever their issue might be with the kidneys. The physician has written orders. You're trying to help this patient become comfortable. NPO means nothing by mouth. You may or may not know that, with the exception of clear fluids. He obviously has some IV fluids running. That dextrose 5% is going to help keep that blood sugar level up so we don't just bottom out since he's not eating. And having a difficult time starting the peripheral IV. A lot of times these patients who are dehydrated or sometimes who have certain conditions can be very difficult as far as starting an IV. So think about those things as you start to look at absorption, distribution, metabolism, and excretion throughout this chapter. So anytime you have any type of liver impairment, you automatically should think about the metabolism, because remember, every single thing that we take goes through the first pass effect in the liver. So make sure that when you look at anything, testing, case studies, anything at all whatsoever, when we're talking about any type of liver impairment, then you're going to think about that distribution and the metabolism of those drugs, okay, because they may need to be adjusted to your patient's condition. So keep that in mind as you're looking through this chapter and as you begin to take your testing. So now we're moving into chapter 2, and we're going to start talking about regulations for nurses and who and how they control medications. So the federal, at a federal level, they actually control how drugs may be given. Okay, state controls who can prescribe, who can dispense or administer drugs, and the process of doing so. This is one of the reasons I wanted you to first start doing that assignment so that you could see what you can and can't prescribe, or not prescribe, you're not a prescriber, but administer. And also that those are state mandated guidelines that we have to follow, and they vary from state to state. So I just wanted you to kind of be familiar with that so that you'll better prepare yourself for your new job on the floor, and also as we move through this, you'll understand the process of these regulations. So hospital or agency guidelines, these are guidelines and policies of how and when the drugs are given and the required documentation. So in the first chapter, of course, we talked about every facility may be different. It just depends. They may have a different timeline for certain drugs based on different reasons, labs, availability of staff, anything of that nature. Okay, so always refer to your policy guidelines when you're looking for those. So let's start with our federal law and their regulations. So they have 3 categories of drugs that they oversee. So this is where you guys are more familiar with the U.S. Food and Drug Administration, or the FDA as we typically refer to it as. It was created in order to monitor testing, approval, and marketing of various drugs. Okay, so when we talk about purity, you'll hear different manufacturers talk about the purity of their drugs and things like that. So in order for them to have those pure ratings, they have been FDA approved. So their laws define 3 categories. I've listed them here. They have controlled substances, which is going to be your narcotics, your sedatives, and your tranquilizers. Okay, and you can see the examples that I've given you here of each of those. I'm not going to read them to you. Prescription drugs, of course, are Cipro, ciprofloxacin, clindamycin, amoxicillin, those type of antibiotics and things like that. And then they also regulate the over-the-counter drugs. We don't normally think about the feds monitoring those, but they do. The Tylenol, the NSAIDs, cough medications, Pepto-Bismol, all of those are regulated by the federal laws. Okay, so we'll talk a little bit more about the classifications of those as we move into the next slide, but just be familiar with the 3 categories that they control and what entails or what is involved in each category. Okay, so your controlled substances again are going to be your narcotics, your sedatives, your tranquilizers, prescription drugs, and then your over-the-counters. Okay, I know you know what over-the-counters are. I don't have to remind you of that, but be familiar with each group and what's contained in those. So controlled substances, if you will look on page 13 on table 2.1, you'll look at this same table. There are 5 schedules. These were created by the Controlled Substance Act of 1970, and this lists from the most addictive to the least addictive. So Schedule 1, this is your heroin, your LSD, and your marijuanas. These tend to be listed as medications, or I'm sorry, drugs that are highly addictive and have very little to no medical use at all whatsoever. However, recently we've heard a lot of talk about marijuana and how we are trying to change the stigma attached to marijuana. I personally am a proponent of marijuana. I do believe that it works in certain cases. However, I'm not really sure how the government will control that disbursement appropriately, but I do see some medical or medicinal uses for marijuana. So I am not disagreeing with them, but just know that it is considered a Scheduled 1 drug as of now, and it has, in their opinion, in your book, no medical use, and they are considered highly addictive. So Schedule 2 drugs are actually, of course, highly addictive also. Your morphines, your cocaine, and your fentanyl. Now, believe it or not, cocaine used to be a medication that they used, or a drug they used years and years and years ago. They would use it for patients who came in with nosebleeds. They would snort it, sniff it, however they got it in there, and it controls that bleeding. I'm not really sure. I don't know the story behind removing that drug from use, but I can understand it's probably related to the highly addictive properties. But morphine and fentanyl, of course, are certainly things that we use all the time to control pain for surgeries or any type of traumas, anything of that nature. But they are extremely, extremely addictive. So those are Schedule 2 drugs, and you guys do need to be familiar with what schedule they fall within, okay, from the most addictive to the least addictive. Now, Schedule 3 drugs are your steroids, your hydrocodone, and your Lortabs. We all know that addiction can happen even with hydrocodone and a low addiction rating. We know lots of people who are walking around in this world who are addicted to Lortabs and hydrocodone. And steroid is, of course, controlled, but many people still use them. So one of the lower ones, of course, on the schedule is going to be Schedule 4, which is your antidepressants, your Xanax, your Valium. Valium can be very addictive too. It's a great muscle relaxer, but it's also wonderful for sleep. So people become very addictive to that Valium for sleep. Schedule 5 is the least addictive. This is going to be your cough medications with codeine in them. So yes, you get them at the pharmacy and they're minimally addictive, but again, you can have those patients who become addictive or dependent upon certain things, whether it be a cough medication with codeine in it or mouthwash with alcohol because maybe they can't afford to buy alcohol. So, it's out there and we just need to be aware of those things. So the Drug Administration, the DEA, actually controls the assignment of the drugs on this schedule. So they are the ones who actually put specific medications into what schedule category. Okay, so now we want to talk about physical dependence versus psychological dependence since we've brought up addiction. So physical dependence, of course, we all know is a physical dependence. I am in excruciating pain. I have to have this pain medication in order to function daily. Okay, that's going to be your physical dependence. I cannot function without it. And it doesn't necessarily have to be a pain medication. It could be something that controls maybe, trying to think, sorry, I'm at a loss for words, arthritis. I have to have a certain medication, maybe that steroid or something else in order to function, to perform my activities of daily living. Now, psychological dependence is something that is, you guys are familiar with it too. Most people, they they don't necessarily need it, but in their mind, they're fearful of letting that go. So I've been taking Lortab for a while, for example, and I've not had any pain, and maybe it was post-surgical, and I feel like I still need it because I'm afraid I might experience pain. So if that makes sense, that's a little tidbit in the difference between physical and the psychological dependence. So as we talk about the different dependencies, we want to make sure that we understand the difference between the physical and the psychological in the withdrawal symptoms that they may experience or the difference in those experiences. So with a physical dependence, if you are trying to stop that medication or lower a dose, this is when you're going to start seeing the side effects, the shaking, the excessive pain, maybe gastrointestinal pains, seizure activity if you just stop it abruptly when you have that physical dependence, sweating. Okay, many of you are probably aware of the problem that we have rampant in East Tennessee, and that is drug addicted babies. And if you've ever been around one or worked in the NICU as a volunteer or whatever, you see them experiencing those withdrawal symptoms after delivery because they too have had that physical dependence while they were in utero. And then once the cord was cut, they're no longer getting that drug that they were getting previously. So they have that physical dependence that has been cut immediately when the cord was cut. So they're going through those withdrawal symptoms. Okay. Now the psychological it's basically just that desire for a drug. They want to get high, or, it's psychological in that they just fear letting that drug go because of what they might experience. So basically, the difference is physical and psychological. One has true visible withdrawal symptoms. The other is just psychological. They either just are afraid to let it go or they have an extreme desire to just get high. And that's going to be with your morphines, your fentanyls, or even your Lortabs. Okay, they just want to feel that high. So make sure that you understand the difference between physical dependence and psychological dependence and what each one of them or I guess I should say what you would assess or be able to assess in a patient if you were trying to determine physical versus psychological dependence. Okay, so when you're doing an assessment and it's physical, you're actually going to see that shaking, the pain, the seizures, the sweating, okay, that maybe nauseousness and those GI pains. Okay, so psychological, you can't see that dependency. It's a feeling. So know the difference between those because I promise you will see those on testing. Now, as we talk about controlled substances, we realize that they're all controlled by at every level, federal, state, and then our agency in which we work for. So controlled substances, narcotics especially is what we're referring to, always must be counted when you come on shift and when you leave. So that gets counted maybe even 2-3 times a day. It just depends. But absolutely positively at each and every shift change, you're going to have someone do a narcotic count. So typically these are kept in a locked cabinet if you don't have some type of Omnicell or medication dispensary system. So with this locked cabinet, these narcotics must be behind 2 locks. Okay, typically there's 2 keys, excuse me, but at least one key is controlled by either your drug nurse, as they may be labeled, or your shift leader. Okay, so all of those narcotics are kept under lock and key. Now, all of them have to be accurately recorded in order for the inventory and everything else to come out. With pharmacy and everything that we have given, everything that we've wasted, if you accidentally open a pill, many times if you've ever been in a facility or even yourself, you've opened a pill and what's the first thing that happens? It falls on the floor. So at that point, we're going to have to waste that medication because we don't want to give someone a dirty pill. So we need to make sure that we are, in fact, keeping accurate records of wasting. Now, when we do a waste of a narcotic, you always have to have a witness. 2 people must sign the inventory receipt or inventory sheet to document that. I would also document it in, some facilities have just a wasting record book that they keep. It just depends on your agency and the facility in which you work. It may be that you just key in your fingerprint and your second nurse comes in and fingerprints also on the Omnicell for a wasting. Okay, so just be mindful of accurate record keeping. If pharmacy is the person who comes up to restock that inventory in your Omnicell, then they are too responsible for doing narcotic counts at certain times in order to maintain their accuracy in their receipts in their area. So absolutely no borrowing. If I'm in the NICU, I use that as an example a lot. We have 4 or 5 patients in one area. My patient may have a medication that's due at say 2 o'clock, but I haven't received mine from the pharmacy yet. but my baby next door has that medication available and it's not really due till 6, and I know they're really behind downstairs, so I'm just going to maybe go borrow that from this patient, and then I'll just exchange it for my patient's medication when it comes up. That is absolutely unacceptable. Do not ever do that. You never borrow from the patient next door, and you never borrow medications from another floor. Okay, so absolutely no borrowing under any circumstance. Now, we can all look at the statistics. On average, there's about 10% of healthcare workers who have some type of substance abuse history. It's proven. We have the statistics to support that. So with that comes a risk for diversion. It's not always related. You may have nurses who have absolutely zero, or healthcare workers who have zero abuse history, but something in their life has changed, and now we're seeing things being diverted that were not before. So we always want to make sure that, again, going back to that record keeping, that's important for that risk of diversion, okay, or truly proving that there is some type of diversion going on. Dropped or spilled medication, just as I said, it has to be accounted for. It has to be co-signed. And I can promise you, if you see that on my tests, you will also most likely see that on NCLEX. So be sure that you remember that. We all have a legal and ethical responsibility to report possible abuse and diversion. Now, in this slide, we're talking about narcotics. So I have worked in healthcare for nearly 10 years. I have encountered 2 instances, separate cases, in which one was medication diversion, narcotics. A nurse was, in fact, taking morphine from our dispensary and taking it herself rather than giving it to the infants who it was prescribed for. So that situation was resolved, and there was another incident in which I was personally involved, in which I was giving a report to a nurse who I felt was under the influence. I wasn't really sure what was going on, but I knew that I did not feel comfortable giving a report to this nurse, as she was unable to take notes, listen to report, and she had slurred speech. She couldn't really walk without swaying, nearly falling, catching herself on a table. So that was not a drug abuse situation. That was an alcohol abuse situation. But we have a legal and ethical responsibility as that patient's advocate to report those incidences. Now, yes, at that point in time, it was proven that she was under the influence of alcohol. So thankfully, I was a new nurse. I was afraid to go to my supervisor, but I had a responsibility to my patients and their families to report those things that I had a gut feeling about, and I went with my gut. I reported it, and it was in fact true. So we went through the guidelines for, I guess, rehabilitation for that particular nurse, and she is now back in practice. And of course, the Tennessee state guidelines, they have their own guidelines for nurses who want to continue practicing, who may have, some type of abuse history or has been caught in a situation where diversion was going on. There's always some educational piece there. So just know that anytime you have any suspicion of abuse or diversion, it has to be reported. So go to your through your chain of command to get that taken care of. Okay, most of the time they can keep your name quiet. We won't put you out there as a tattletale, but remember, you are your patient's advocate, so it is truly your responsibility. So remember that we have a legal and an ethical responsibility to do so. So we've talked about narcotics and how secure we keep them under 2 locks and 1 person with a key. So let's say at the end of your shift, I want you guys to think about this because it's important. It's the end of your shift and you are doing a narcotic count with another nurse so that you guys can report off and go home. Sleep well knowing that everything balanced. So you find a discrepancy. There's a bottle of morphine missing. Let's just use that for instance. So who are you going to report that to? What records are you going to reconcile? Or how are you going to reconcile this error? How are we going to come up with this bottle of morphine that's missing? So first of all, you always want to make sure that you report it off to your shift leader, your nursing supervisor, and your pharmacy. Okay, maybe pharmacy came up and restocked your supply and maybe entered it incorrectly. That is a possibility. So always make sure you notify all of them. You want to make sure that you're checking with every single nurse that has been on your floor administering drugs. You don't isolate anyone or just say, well, so and so, I suspect, didn't chart hers. Again, just make sure you're asking every single person. Don't single any one person out. Okay, ask every single nurse on your floor if they forgot to document any narcotics, whether that be I gave it and failed to document it, or I had to waste it because I dropped it and the bottle shattered. Okay, just make sure that every single nurse is asked about the medication that they obtained. And then, of course, we always have reconciliation. When you take those medications out of that locked area, I know I worked in a surgery center, and anytime we took medications from the locked cabinet, we had to do a transfer. And so you had to have two signatures. So I know in a perfect world, we never do anything without going by the book. We know in the real world that's not true. So there were many times that our count was off because we failed to chart some of those medications because we used paper charting. So just be mindful to always double check all of those things and report those. Okay, so check your drug records to reconcile. Ask every nurse that has been on your floor that administered medication, and then you also want to report that to your pharmacy, your shift leader, and your nursing supervisor on your floor. Okay, so just remember those. Those are important for you to know. With prescription drugs, again, we've talked a little bit about those and that the FDA actually regulates those. Um, so the Drug Enforcement Agency, and there's also a Practice Act that describes who can actually write prescriptions. Okay, so that's going to be your physicians or some dentists. They have medical license, so they're actually going to have those writing privileges. But your FDA, your DEA, and that Practice Act will spell out who actually has writing privileges. We as nurses know we do not have the privileges of writing prescriptions. Okay, we can verify the orders, but we cannot in fact write them. So as we're talking about prescription drugs, we also want to talk about insurance coverage. Okay, so oftentimes insurance coverage that your patient has will determine which medications are available to them. So there's one in particular, Medicare Plan D. They can have a subsidy of those insurances, okay, who pays for drugs, and they limit the type of drug and the amount that they're going to pay for a certain drug, sadly. So they may get a preferred medication versus just whatever's available or whatever. Okay, cost is always in the back of your mind, and of course, we all know that money makes the world go round. So naturally, they're concerned about cost. So prescription drugs make up the most of the drugs that you're going to give to a patient in nursing homes, assisted livings, and hospitals. So naturally, they are taking up the cost for those medications. So they may look at what's preferred rather than just whatever's available, depending on what your patient says they prefer. Sometimes I prefer to take generics just because they are cheaper. They're all covered by the FDA and their quality. So what does it matter if I pay for a name brand? It's kind of like wearing a certain name brand jeans versus Walmart jeans. Just because it has a name brand does not mean it's any better or more effective. Okay, so just be mindful of that. Now, we've mentioned over-the-counter drugs. We all know what over-the-counter drugs are. We do not have to have a prescription to obtain them. So we have to talk about the safety aspect of over-the-counters. So Yes, they're considered safe for the most part, but are they really when we look at all of the interactions that can happen when you have patients who are taking over-the-counter medications mixed in with their prescription medications. Okay, so one that I typically refer to as Sudafed. Okay, for colds, typically it's what you would use it over the counter for. Um, Vitamins, cough syrups, those type things. Sudafed and cough syrups especially, we know contain other medications, pseudoephedrine. This is why we used to have to show ID to buy Sudafed, because of the pseudoephedrine. People were actually buying Sudafed in bulk to make meth. So that's why they came in and they decided they actually removed that from Sudafed in order to put it back out on the shelves. But you can see that they're not really safe unless we use them safely. Okay, so some over-the-counters when you're in a facility, if you have a long-term care facility, stool softeners are typically an over-the-counter. Some cough syrups, melatonin, and vitamins are over-the-counter medications that can easily be obtained. However, if you are in a facility and your patient is taking any of those, that has to come from pharmacy. They actually have to key in an order for that specific stool softener or that cough syrup or vitamin or whatever. So that's going to come from your pharmacy. Okay, they are not allowed to use or bring their medications from home if they're in just, on the med surg floor for 3 days or whatever. They can't just have family members bring those in and start taking them. Okay, it has to come from your facility's pharmacy because we want to do a drug reconciliation. We want to see if they're taking anything that might interact with that vitamin or that cough syrup or, something like that. And then we always have to be mindful of supplements and herbals. Yes, they're controlled to an extent, but not as closely regulated as our narcotics are. Okay, so turmeric, these are some of the ones that are extremely popular and have the most interactions with medications. That's going to be your turmeric, your St. John's wort, and then the popular G's, the garlic, the ginkgo biloba, and the grapefruits. Okay, you will hear about grapefruit and its interaction with medications throughout this entire class, also with St. John's wort. So just be familiar with those. And we'll talk a lot more about what those interactions are as we move through the chapters. But just know that those are not always safe. Okay, St. John's wort actually interacts with a lot of blood thinning agents and your psych medications because it can affect your melatonin. Not your melatonin, I'm sorry, serotonins. I'm on the wrong herbal there. So we'll talk about what those affect, but just know that they're not always safe unless they're used safely, okay? And some of our patients may not even be aware of those interactions, okay? So that's why it's important for us to know as nurses either what those are and how they interact or where to go to find out how they interact with certain medications. That's where your drug books are going to come into play, okay? So over-the-counters are not always safe. Make sure that you're aware of that. So we touched base about a legal prescription in the beginning of this lecture when we were in chapter 1. So again, legal prescriptions have to have various items: patient name, the date, name of the drug, the route of administration, the dose, frequency, the duration, such as antibiotics or something like that. How long are we going to give it? Okay, and then the signature of the prescriber and their DEA number. Now again, there can be electronic signatures or wet signatures. If they're actually signing on a prescription pad to give to you to take to the pharmacy, that's a wet signature. So just know that they can be electronic also, but it has to have the signature of the prescriber. Now, with those prescriptions, also they need to include additional instructions. Those instructions would be such as no milk or avoid with those grapefruit juices, or take with food so they don't have that GI upset, may cause drowsiness. So if you know that a medication is going to cause drowsiness, you probably want to make sure you educate your patient on driving, or again, you'll see that do not operate heavy machinery. Okay, a lot of medications also can cause some sun sensitivity. So we again ask them to avoid sunlight, and we're putting those labels on the prescription bottle. Okay, Do not crush or chew. Those are important too. Remember those time release capsules or those enteric coatings, things like that to provide that longer dosages. Okay, so don't crush or chew. No milk. Take with food just to avoid some of those GI side effects. So those are part of the prescription that need to be included. And in one of the slides that follow, you'll see those on those prescription bottles, okay? So this again is just some of the warning labels that you will find. And this is where those additional instructions come from, are those prescriptions. So rectal use only, shake well before using, may cause dizziness. You'll see there's one, keep out of reach of children, do not take with alcohol, may cause drowsiness, take with plenty of water. So you get the idea of what those additional requirements are for medication prescriptions for safety reasons, okay? External use only. I know you're probably thinking sometimes I should know or I should be able to assume that my patient is not going to chew a suppository. However, we all know that we have warning labels for reasons. It's happened, so we've created a label for that. So just know that these are some of the things that you may see. These are your warning labels, okay? And those are actually stuck to your bottles when you pick them up at the pharmacy, okay? So if you have any questions about any of those, again, please let me know. So as we talk about prescriptions, again, we're going to go back to those prescriptions and why is it being prescribed? Some facilities want a justification on there for that drug. Lisinopril for hypertension, okay, whatever opioid for pain. Okay, so we all know that written orders are the safest, and I'm telling you this because I want you to be mindfully aware of the fact that if you're taking a test and it asks you about orders and which is the safest, you need to know. Okay, so written orders, of course, are the safest if they're written legibly. Okay, that's always a hurdle when you're dealing with written orders. Okay, verbal orders are the least safest. If you guys think back to the video you watched in the beginning, there was a chain of events that led to a miscommunication about medication and the name of it. And it basically boiled down to a failure to verify, okay? So verbal orders, we always want to make sure that we are reading them back to the prescriber. Once we've written them, we verify the accuracy, okay? Especially if we're on the phone. Even in person, we still need to do it, but especially if we're on the phone, okay? You can put that on speakerphone and have someone else listen in so that it makes you feel more comfortable that you have, put those triple checks in place, okay? So verbal orders must always be read back and verified, okay? They also, once you write the order, if you actually key that order in or you write it on paper, some still work on paper, they have to have a prescriber signature within 24 hours, okay? Typically that's a facility policy, okay? So when you're documenting those telephone orders or those verbal orders, you're going to write, you'll see I have on this slide VORB. That means verbal order read back. Or you could put TO for telephone order read back. Okay, so you have verified that order. You read it back to the physician. Okay, and you're going to actually sign that, but they're going to come in and co-sign with you to show that they actually gave that order. Okay, now I also have here the nurse practice. Can't talk, sorry. Nurse Practice Act, the guiding governing. Okay, we did that in the beginning. Okay, so you know what the Tennessee Nurse Practice Act is, and you know your rules and regulations as far as guidance in medication and safe delivery as an LPN. So let's talk about the types of drug orders. You have standing orders, you have stat orders, you have single orders, and then of course our PRN orders. So our standing orders are just that. They're a standing drug order. It's the same prescription every single time for the most part. Every single physician follows this. Okay, so for example, ibuprofen 600 milligrams every 6 hours. Amoxicillin 500 milligrams every 8 hours for 10 days. Okay, so let's say you're in a pediatric unit and you're working, and based upon admission for XYZ, or if you get a blood culture for XYZ, this is going to be your standing order. So if that blood culture comes back for XYZ, you have a standing order to start treatment with amoxicillin 500 milligrams every 8 hours for 10 days. Okay, so that's your standing drug order. So upon admission, a lot of times they will have that standing admission orders. Okay, so same thing, standing drug orders. Okay, it's the same. So your stat or your emergency drug orders are, let's say you have a patient who's had an allergic reaction and you need to fix it immediately. We need to give them some of that Benadryl, that diphenhydramine, and we need to get it in immediately. Okay, kind of like an EpiPen. Okay, so if you're there and you have a patient whose airway's closing off, we want to fix that pretty quickly. So we're going to give them a dose stat of Epi, okay, to clear that reaction. LASIK, okay, I can remember the first time I was on a floor by myself, I had an LPN on the floor with me, and I had a patient who was perfectly fine when I went in to check on her at like 9 o'clock. I was making another round, and she suddenly looked gray, and her oxygen saturation was dropping. She looked terrible, and I was in panic mode. And so I called for what then was rapid response. And so what she had was called flash pulmonary edema. Her lungs had just immediately started filling with fluids. And so I needed to get rid of some of that fluid quickly. So I had a stat order written for Lasix or furosemide stat. Okay, so that's your stat orders. You need it right then, right now. Okay, so then you have single drug orders. Okay, so a lot of times before surgery, that's why I give this example, they will have antibiotics that they want to give, and it's typically about an hour prior to surgery that they will give that one-time dose. Sometimes you may have a patient that's like, no, I kind of have a headache, and they'll give you a one-time dose for Tylenol or something like that. Okay, it's something that we're not going to give more than one time. Okay, if we give if we need it more than once, then they're going to write just a regular order for that, okay? PRN, as we've talked about previously, that is just as needed, okay? That's for typically headaches or pain is what I see most of the time, or once in a while I've seen stool softeners or for constipation, which is what I have here. So those are your PRN orders. Those are just as needed, okay? So just know the difference between those, when you would use those as a nurse, okay, and which ones you could repeat or you couldn't repeat, okay? So just be very mindful of those. If you have any questions about any of those, again, please write those down, email those to me, and I will elaborate on those. So this relates back to your first assignment in the Nurse Practice Act. Okay, so our state laws vary, as some of you may have seen. If you looked up North Carolina or Tennessee and their practice acts, you may have seen a little bit of difference in those. But this is important, and this is why I gave you this assignment, is because I want you to understand that each state may have their own practice act, and you need to be familiar with the ones that you're practicing under in your state. Okay, so you did this assignment, you know what you can and can't give. You know your weight limits. Of course, I have that listed here. So you guys are very familiar with this. You can read over this slide. And if you have any other questions about those, please let me know, again, by email. You guys have already looked at this, so you know what you can and cannot give. Okay, so if you have questions, again, please let me know. This is just a continuation of the previous slide talking about your nurse practice acts and, of course, delivering the medications that LPNs can and can't deliver, okay, or patients that they can't care for. There are instances in which an LPN, once they've reached a minimum of 6 months and they've been licensed or working in a facility, they can actually complete certain courses and become certified to do certain medications or um, taking care of IV lines. Okay, so just know that sometimes you may see an LPN doing some of those things that we've just looked at that tells you you can't do. However, they've met that 6 month requirement and they've actually gone through the training and the courses to establish proficiency, and so they can actually use and administer those medications at that point. Again, I said states can differ, so you always want to make sure you refer to that Practice Act if you're going to another state. We have many compact states, but again, always check those. As far as ethical and legal responsibilities, you looked at your Nurse Practice Act, so you should know what those are. Always know in the back of your mind that we as nurses, we are not immune to the legal responsibilities and fines that we can incur when errors happen, or any type of disability that might happen, anything like that that might be harmful to the patient. Okay, so a lot of us carry private insurance to protect our homes and whatever else because of that huge responsibility and the legal aspects of that. So just a continuation of the previous slide. If you have questions, please let me know. So drug administration systems. So when we're talking about the administration systems, those can differ from facility to facility. You may work for a Ballad facility, but you may work at two different hospitals and they have two different types of either IV pumps or feeding pumps. Sometimes even syringes can be different. So it's just facility specific, even floor specific. Okay, so you just have to kind of be familiar with tons of different kinds of systems. So if you're not comfortable, you've never used it, don't ever be afraid to go to someone and say, hey, I've used this a couple of times, but I just need someone to verify this. There is nothing wrong with that. Okay, don't ever be afraid to go to a senior nurse and say, hey, can you help me? Okay, and if they give you grief because you don't know how to work it, then remember that's a problem with the nurse that you have sought help from, not you. Okay, it is perfectly fine to seek out help. Barcodes and scanning. This is a system that we used when I worked in the medical center or at JCMC. Barcodes. We had barcodes for our medications, and we had certain for safety reasons, we had scanning devices, of course, that we used for, of course, verifying our patient, verified the medications, and things of that nature. Again, we talked about this in the beginning. Do not ever, ever, ever leave a medication at the bedside or with a family member or a CNA. They are not licensed to give medications. Okay, a CNA, you cannot delegate that to a CNA. You can ask the CNA to do whatever is within their scope of practice, but you cannot ask them to give a medication. I do not care if it is a stool softener or a narcotic. It is still a medication and you cannot leave it with a CNA. If they're in the middle of giving a bath, then you come back and give it. You don't leave it on the table for another person to give. If it's a narcotic, especially, who knows? Maybe you have a family member who's diverting that patient's drugs. Okay, so you have to be mindful of those. Okay, be on your toes. Now, as far as documentation, they have different systems. So when you use a scanning system with the barcodes, it automatically puts that into your electronic medical record or your medical record, whatever system they may use for their drug orders. So I know when I worked in the NICU, we had what we called cardexes, and we always kept our medications written there. And we would always update the time of administration for our, especially the PRN medications. Well, you can understand how difficult that would be if you are giving a pain medication and you suddenly get called away to a code or something of that nature. So cardexes are really kind of a prehistoric way of keeping record of medications, I guess that's what I would say. So the electronic system is always the best. Remember, you always want to make sure you document after the medication is given. Do not ever leave it. You don't chart it either until you actually have put it inside that patient's body. Okay, so you didn't give it if you didn't see it go inside the body. Okay, so just always remember, never be afraid to ask for help. All of your devices, your systems may be different. So just be mindful of those. Okay, and remember when you're delegating to a CNA or an unlicensed person, when you get out on the floor, you're the licensed person and that is your license on the line. Okay, so be mindful of that. So drug errors can occur in many stages before it gets to the patient, causing um, even up to fatalities. Okay, it could just be an allergic reaction or fatality. So always remember that. It can occur during preparation. It can occur during the delivery to the patient if we give a medication IV that should have maybe gone IM. We don't ever want to do that. So again, it can occur from writing to the pharmacy to us not verifying correctly. Okay, so there's many reasons. Human error is, we're human. Mistakes happen. Okay, so this is when our ethical responsibility comes into play. We have to report any drug errors, even if there was no harm to that patient. We gave a medication inadvertently to the wrong patient and there was no real reaction, nothing really happened to that patient. It was still an error, and we need to report that because we need to, what will happen is they will do what they call a root cause analysis to find out where that breakdown was, how this error occurred, and are there other safety measures that we can put into place to prevent that in the future. So that's why it's important to always make sure that we are reporting those errors, even if there are zero harm or zero anything to the patient, okay? These are not meant to be retaliatory. These are meant to be learning opportunities and opportunities for improving the system to, I can't really say become fail-proof because nothing is really fail-proof, but it allows us to be able to improve the process so that we can prevent those errors. Now, how do they occur? You'll see in this slide that I do have a YouTube video there. So watch this video, and as you're going through the first time with this video, look at the different times with the different or the number of occurrences in which this error or this I guess error in judgment or could have been avoided in this video. Of course, this was a training video. It wasn't true. So just kind of watch through this video and think about how in our practice when we work in a facility, if you work in a facility already, how many times that happens to us while we are actually at work. I know many times our might be in medication room mixing medication and someone will say, hey, can you come look at this, or can you verify this or that? So we always have those distractions. Even patients sometimes can come into play as far as distractions. So in order for us to decrease drug errors, there are many things that we can do. So watch the video and just kind of be mindful of some of those things that we could eliminate or speak up about to reduce those drug errors. So I want to talk about high alert drugs. I talked a little bit previously about insulin and how it is a high alert medication, and you have to have two nurses verify the insulin prior to giving that. Well, that's not the case with all medications, okay? We all know that high risk drugs are labeled that for a reason. Well, it's because it can cause great harm, or your patient is at great higher risk for harm if maybe that patient is given this drug, but they are not prescribed this drug at all whatsoever, or you've given this drug at a higher dose, it can truly increase their risk of harm. So any high alert drug, you can memorize those by using the acronym PINCH. Okay, so P is for potassium, I is for insulin, N is for any narcotic or opioid, C is for chemo, and H is for heparin or any of those anticoagulants. Okay, this can cause great harm to your patient. Okay, so any type of error within those can cause great harm. So there's a little snippet on this one, a YouTube video. Please watch the videos that I have put in here because a lot of times these can trigger memories. You may be testing and you're like, oh, I remember that video. So I put these in here to kind of give you a visual because I know this is a different learning environment for you. But just be sure that you're looking at these videos. So this one again is about the high risk drugs, the high alert drugs. Now, many times high alert drugs are either labeled differently. They may have like red lettering, or I know with insulin, when you're storing it, it has to have a red dot on it in order to alert your nurses to the fact that it is a high alert drug. Most of the time, we should, if we see something red, it should trigger us to stop and pay attention to that. So always be mindful. If you see those red dots, typically on medication, that means it's a high alert drug. Okay, there's a high risk for harm for your patient. So watch the video. It will talk a little bit more in depth about these and hopefully trigger, some memories while you're testing, because I 100% guarantee you're going to see these on my test. Okay, so make sure that you know what they are, and that it can create a huge, huge issue for your patients if we give them something. If you give them potassium, what is that going to affect? Your cardiovascular system, your heart. Okay, insulin, any type of opioid, you can cause them to be comatose, and we're going to have to reverse that. Okay, chemo, we don't want to give that to a patient who doesn't even have cancer or anything like that. So we have to be very mindful of those. Medication reconciliation is a vital piece of nursing assessment. We compare the patient's history of medications to the medications that you currently have in your facility. So, or if you have a patient who's coming in for surgery, you may call them the day or 2 days or whatever your time frame is um, prior to their admission to reconcile that medication or to get those medications from your patient so that you don't give something to them while they're under your care. If it's an outpatient surgery, that might interact with something they're taking on a daily basis. So with medication reconciliation, we always look at, are they getting what they need? Um, what maybe your patient is taking something for blood pressure and they've gone to another physician and they don't realize they're still taking this medication from 6 months ago from another physician. So this is where you get into that polypharmacy. Okay, so I may pick up a prescription at Walgreens, but the Walgreens pharmacist doesn't really talk to the Walmart pharmacy. Okay, their records never cross. So polypharmacy is a huge problem in the geriatric population. Okay, they don't know 9 times out of 10 what they're taking and why they're taking it. So medication reconciliations are extremely important. They may be double dipping, as I say. They may be double medicating. And so if you're taking 2 medications for blood pressure and you're bottoming out, that's a problem. Okay, so polypharmacy is widespread problem, especially with our geriatrics. So just know that we have to educate our patients and we have got to be vigilant in our medication reconciliations as nurses. Okay, if you ever have a question, remember not only as far as prescription drugs, but those over the counters. Am I taking something for maybe a psych disorder and I'm also taking another medication that increases my endorphins or increases trying to think of the word. Gosh, I was totally blank. Dopamine. Sorry, I was trying to think of the word. I just totally went blank. So am I taking something that is prescribed, and then I'm also taking some herbal medication that has been shown to increase dopamine levels. So I'm increasing my dopamine on 2 occasions. So is that safe? Okay, so not only prescription drug medications, but also making sure that we're looking at over the counters, because again, they may be taking Tylenol, but they may also be taking a cold medicine that also has Tylenol in it. So we always want to educate and reconcile those medications and make those patients aware that they're double dosing with those. So when we administer all of these medications and the different devices we use to administer them, we put ourselves at great risk of exposure for different injuries. Of course, needle stick is one of the big ones in nursing. We go through a lot of education for needle stick prevention. Okay, we do that yearly. We are required to do needle stick prevention education yearly. We also as far as OSHA, we are required to have those sharps containers available within close proximity of your patient so that you're not carrying another drug out by your patient. We don't want to tote them to the outside of the room. We want to dispose of those needles as quickly as possible. Um, We have other protective gear such as gloves to prevent any type of skin contact. When I think of those, I think of chemotherapy drugs. Of course, you have to have a certification to deliver certain chemo drugs. So they have certain gloves that they use and certain, of course, protective wear, PPE that they use for administration of chemo drugs. We all have or will be, if you haven't been, educated on exposure, the protocol for each facility that you work in. Okay, if you are victim to a needle stick injury, then what is the protocol for that? You know, typically you'll clean the site, report it, paperwork's done, you'll go to the ER for some testing, and that varies by facility. Okay, so just always be mindful of your safe equipment. Use your needleless devices. A lot of facilities don't even use needles. Okay, they have a needleless system, which is really nice. So always make sure if you have those available that you use them. They are required by OSHA to provide certain PPE for us, as we all know, sometimes with the new COVID that came out. Safety equipment and OSHA's control of that and how that's to be used has certainly gone by the wayside, or at least been strayed from. So if you look on page 21 of the book, you'll see a safety alert at the top, and it's in the little red box, and it just talks about the safe disposal of drugs even. Now, I don't know if many of you know this, but most facilities like your police departments and things like that, they have what they call, I don't know, a drug, I forget what they call it, but they have a system set up where they will allow you to drop off prescription drugs that you want to have destroyed, or, you know, whatever you need to properly dispose of. So those are available somewhere within your community. And so the safety alert on page 21 just talks a little bit about that disposal of those. We don't want them to pollute the environment. Okay. We don't want to just throw them out in the trash and then someone be digging through our trash and get their hands on certain drugs. Okay, so there's always safe disposal systems